Hello, everybody, and welcome to StoneSmart Live. So StoneSmart is a Boston Scientific thought leadership program focused on cultivating conversations about your most challenging stone cases. And the StoneSmart Forum is an interactive site on Urology Times, where you can view stone case studies and discuss challenging urology issues with all of your peers as you all advance the science of endourology. Now, we are here today at the 2017 World Congress of Endourology in Vancouver for a live discussion of some of the cases that are featured on stonesmart.urologytimes.com. Now, today, I am so pleased to have Dr. Cho with me as our guest. Sung-Young Cho is a urologist and assistant professor at the Boromei Medical Center of Seoul National University in Korea. Welcome, Dr. Cho. And he just informed me that Sung-Young is the same as Jackie Chan, so he is a rock star and a movie star today. So we're really happy to have him here. How are you today?
Yeah.
I know I didn't embarrass you, did I?
Thank you for the invitation. I'm very pleased to be here. Yeah.
Well, we're really happy to have you. Stone dusting as a technique for treating kidney stones, urologists tell us that they need an effective way to really maintain visibility and evacuate dust during the procedure. Now, Dr. Cho developed an interesting new approach to this challenging problem. He uses a double lumen catheter to optimize visibility of the surgical field and efficiently evacuate dust. Now, the cases that he shared on the StoneSmart Forum demonstrates his treatment of a 44-year-old male with an 8-millimeter stone in his left kidney. Now, Dr. Cho, I would like to play the section of your case study that shows your dusting and evacuation technique, okay?
Yeah.
All right.
Okay.
So I use the dual lumen catheter for evacuating dust, and the one channel is connected to continuous irrigation system and the other is connected to the suction. So now I put the dual lumen catheter through the ureter accesses to the renal pelvis, and because of the characteristic of dual lumen catheter, the tip of the dual lumen catheter is located to only the upper pole calyx. So the essential points are patient should be lie in the translumbal position, so head down, and at the start of the procedure, I move the stones from lower pole to upper pole, the single, as far as I can, into the single upper calyx. And the stones can gather in the upper calyx, and I do dusting technique. And if the stones are changed into the small particles to go out through the channel of the dual lumen catheter, then I started to evacuate the dust through the dual lumen catheter. And dual lumen catheter size is 10 French, so I usually use the 11-13 French ureteral accesses of Boston Scientific. So I do alternatively irrigation and suction more than 10 times. I do the back and forth movement of the dual lumen catheter to maximize the efficiency of evacuating dust. The procedure should be gentle movement. If the ureter and upper pole calyx is straight enough, you can effectively use this technique. So you can see almost all dust already removed through the dual lumen catheter there.
Well, that certainly is a creative approach to this difficult challenge. So I want to ask you how small you try to get the fragments in order for this technique to be effective and efficient without clogging the catheter.
Yeah, the dual lumen catheter has two holes, and one is located in the distal tip, and the other is the left side. So I think the side hole is larger than the distal, the hole in the distal tip. So I thought I need to remove the stones and residual fragments through the side holes first. But the whole size is at around one millimeter size. So I think the small fragments less than 1 millimeter can be retrieved by the side hole.
Okay, so are you able to remove stone fragments that otherwise would potentially not pass naturally when using this evacuation technique?
Yeah, in my surgical database, the dust unexpectedly, the dust would not go spontaneously so easily during the postoperative 1 year. The passage rate was just only less than 30%. So I need to retrieve these dust postoperatively. So I thought the necessity of any type of device. Because I found the dual lumen catheter in my hospital because, yeah. So I think the two channel is necessary. The one is for irrigation and the other is for the retrieve the small dust. And I think this can be quite efficient for me to retrieve the dust during the surgery, at the end of surgery.
Okay. And how many times do you alternate between manual irrigation and suction to clear, let's say, a 1 centimeter stone, for example? And how long would it take to typically complete that process?
At first, I just tried 3 to 4 times retriever by using this dual lumen catheter, but it was not efficient. So recently, I performed 10 times a set. And a set can maybe 10 times alternation between irrigation and suction. So after I perform 10 times irrigation and suction, I check the status of the remnant particles.
Okay. And how do you assess progress of stone evacuation? I mean, do you have direct visualization throughout the irrigation suction, or do you have to stop and check periodically?
Yeah, because the fluoroscopy has some limitations to identify some remnant fragments in the renal pelvis. And so I think the direct visualization is necessary. So after I perform 10 times irrigation and suction, I put the flexible ureteroscopy into the ureteral access schist to visualize, identify the presence of remnant particles. And if there are so many particles until then, I perform the 10 times irrigation and suction again. And usually only takes 5 minutes. 5 minutes, and maybe 1 or 2 sets would be enough to retrieve the almost all dust.
Well, that's very efficient.
Yeah.
Now, what is your protocol for follow-up post-operatively?
Usually, I think after RIRS, there must be some fragments, very small fragments. So X-ray has a very limitation to identify the small particles post-operatively. So I think the CT scan is necessary. But I discussed this, performing the checking the CT scans with my radiologists in my hospital. So we prepare some protocols of less radiation exposure. So non-contrast, low radiation CT is prepared in my hospital. So I usually check the CT scan within 1 or 2 months post-operatively when my patients visit my consultation clinic.
Oh, great. Now, I know that we were half joking about how your name translates to Jackie Chan, but you have gotten a lot of attention having participated on the StoneSmart Forum.
Yeah.
And as a urologist participating in the StoneSmart Forum, what has it been like being a doctor in Korea, participating in it and getting so much attention? And would you encourage doctors out there to participate and even share their own case studies?
I already recommended to several peers to join this kind of StoneSmart program because we can collaborate many things with other colleagues in other countries, and we can give some of our information to them. So I think this is a very efficient way to communicate with other people in foreign countries. So I think that I'll actively recommend this program.
Actively recommend. I love that.
Yeah.
I love that. Well, our time is up then. Thank you so much for a most interesting discussion. We're really happy you could be here. And thanks to all of you for joining us. Now, you can view Dr. Cho's full case and join the online discussion on the StoneSmart Forum. So just go to stonesmart.urologytimes.com. And to learn more about Boston Scientific's portfolio of solutions for your most challenging stone cases, go to bostonscientific.com/StoneSmart.